right, so here we've got a demonstration of tooth removal of number 18. We've got this little guy here that has some periodontal disease. You can see where the bone level is pretty low on that side, causing bacteria to want to trap underneath there. We've got our PA that shows us a little bit of that information. The bone levels should be around here. The bone level on the back side goes down, allowing bacteria to trap back in there. If visually this was the only thing that was concerning, I wouldn't be as worried about it. However, once we jump in to see what the perio chart looks like, then we see that there's a 9 millimeter pocket with bleeding, and so that's not going to resolve. Anything that's got bleeding and is 7s, 8s plus, pretty hard to treat that. You can treat it with osseous. If there's a 3-wall defect, you can do it with some bone grafting and perio. On a distal tooth, with the way that the bone level is, the way that the ramus comes up against that, there's just not enough room for this tooth in the mouth, and so I believe some osseous surgery was attempted previously on this patient without benefit. So we're going to plan to remove the tooth. So here is the tooth removal process.
I'm going to put this little pillow in here and relax to moment. Okay. All right. First steps, Wonder Woman. Loosen up the PDL. Chin support, please. Thank you.
He's already been numbed up with, I think, carpule of septicane, carpule of lidocaine. He's been given a mouth rinse of chlorhexidine for 1 minute and 600 milligrams of ibuprofen, 1,000 milligrams of Tylenol, and I think we gave him 8 milligrams of dexamethasone in pill form. We also confirmed no history of radiation treatment, no current diagnosis of diabetes, also no heart or lung problems.
Get downward pressure. Some would say downward bog, but only if you're a yoga fan. Okay. Because there's no crown on this tooth in front, you can do the leverage action. If there was a crown there, I wouldn't do any leverage against that tooth. Okay, we're going to do some down, some back facing. We're rotating in this direction. Okay. Push a good wedging, good pressure, rotation, press, 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 press. Okay, we're watching for any little bit of movement. We're seeing a little bit of rocking there. That's good.
And there's not a whole lot of rocking to begin with here, and as I'm wedging this in, I'm putting pretty firm pressure. I'm not putting my whole arm into it. This is mostly forearm right now. You want your arm to brace and support it, but you want everything to be fairly delicate. If you're cranking too hard, then you start to break things. I've seen a case coming from another office in town where the jaw was broken because there's so much force placed on that. These handles, you want to rotate them, but only rotate them up to medium force and give them plenty of time for the PDL to loosen up.
Pressure. Doing great. Press. Press.
And it's tempting to want to rotate the other direction, but trust me, as far as the physics go, the apex is all the way down the fulcrum, and then the pressure, we want to be pressing against the top part of the tooth and rotating toward the top side of the tooth, not trying to lift it up out, but trying to rotate it back, and then I will be showing you leveraging to move it more coronally.
Press and rotation to lift it a smidge.
You'll notice that lifting as I'm engaging, and I'm also lifting the tooth up.
It's a little crunching. There might be a root that wanted to separate. Lifting.
And because that distal bone is moved away from that flexion toward the distal is working just fine. If there wasn't any bone loss in the back, and let's say it was a non-restorable tooth or a wisdom tooth or something like that, and the bone, you can't actually flex back into a space on the distal, I would do a sectioning. I would section the back a 45-degree back distal of that tooth to create some room.
Lifting, rotating, lifting. Okay, he's fairly loose, and to rotate from this back corner here as well. Lift up a little bit from that back edge and the side.
Oh, look at that
and
guy.
Kelly is going to do the extraction here with the suction. Alright. Got a little bit of that distal PDL teasing it and just holding on to it. So. Okay, checking to make sure we didn't lose any root tips. Okay, checking around, that looks good. No root tips remaining. Okay, and we're going to clean out the residual granulation tissue. Go ahead and suction there. Especially on that distal. Okay, and on those sides, very good.
And this is just using the Molt 4.
Got some good healthy heme in there. Thank you. Okay, now we're going to irrigate it really well.
And this is just regular 0.5, 0.6 saline, whatever the isotonic saline is. 0.9, 0.8. Okay.
Just lifting, separating off of that osseous in the back there. The rest of the finger mostly open for me. All we do. Okay, so I roll a little tight here. And slowly close down. Good job, keep it happy.
So that gauze then just has saline in it, and I cut a 4x4 in half, fold it, and then roll it up, and fold it and roll the ends in. So that's it. Good luck.